Okay, so my topic today is blood transfusion and reactions. So my structure for today's lecture, I'm going to start off with the basics, the ABO system, and then the Rhesus system. Sorry if I'm pronouncing it differently. The AB0 and Rhesus systems. Those are the two main blood group systems that are important for blood transfusions. And then the second and third points are kind of belong together. They're transfusion safety and pre-transfusion. So I try to differentiate what happens right before you administer a blood transfusion and what happens, for example, when you're donating blood, to make sure that the future transfusion of that donated blood is safe. So I try to distinguish it between, according to the timeline. And then my last point in the lecture will be the various reactions that patients can have to blood transfusions. And I picked out the 6 most important, most common, and most good to know ones. Okay, so let's start with the basics. We have a ABO system. This is just the table from AMBOSS. And as we know, people can have an O blood type, A, B, or AB. And this is based off of the various antigens that are presented on red blood cells. So O or 0 means that the patients have 0 antigens on their red blood cells. Accordingly, their serum has antibodies to A and B antigens. So whatever the patient has on their red blood cells, the patient's serum has antibodies against the other types of blood, according to the ABO system. So somebody with AB has A and B antigens and no antibodies. And this is easy to understand in the sense that they're not going to have antibodies against their own blood. So that's how this system works. Okay, moving right along. And so this is very relevant for blood transfusion. This is the main system and the most important system when for blood transfusion. The next system that we will be, so very important chart to understand. Does anybody have any questions on this in the chat real quickly? I don't know how, okay. So if I have the chat open, if you have any questions, you can write them in the chat. So this is the most important system for blood transfusions in the hospital setting. And the next system is also important, but in emergencies can be forgotten, I'll say, but it is very important when it comes to pregnant women and fetal-maternal blood exchange. So AB0 system, moving on to the one for the pregnant women, which is the Rhesus blood group system. And the most important, there are tons of Rhesus blood antigens, and the only one you really have to know is the Rhesus D. So whenever anybody says Rhesus positive or Rhesus negative, it's always referring to the Rhesus D antigen. So people can, for example, say, oh, my blood type is A positive. And the positive is referring to the Rhesus and specifically Rhesus D system. So it's the same principle as the ABO blood system. You have antigens. This is the Rhesus factor D antigen. And the person who is Rhesus positive has Rhesus D antigen on their red blood cells, but no antibodies because they're not going to fight their own blood cells. So somebody who is Rhesus negative does not have any Rhesus D antigens on their red blood cells, and accordingly has the Rhesus D antibodies, anti-D antibodies. And here you can already see in parentheses, they wrote after sensitization, and I'll get into this in a moment. But summarize have the same idea, and it is very important to just remember that patients aren't going to fight their own blood, so you have antigenes and antibodies against everything else. Rhesus positive, majority of people are rhesus positive, especially in Asia. I want to say over 95% of people are rhesus positive, and Caucasian people, white people in Europe, 85% are rhesus positive. So the overwhelming majority of people is rhesus positive, and that together with the fact that it is, so it's not as, there's not as much variety, and that's why the AB0 system is most important for blood. Okay, somebody says I'm O positive. So what does that mean if they're O positive? Shatsia says she's O positive. That means that she has 0 antigenes on her red blood cells, and she has antibodies against A and B. The positive means that she is rhesus D positive. So she has rhesus D antigens and no antibodies. So the important thing about the rhesus system is in pregnant women. So if a rhesus negative person, a rhesus negative woman has a baby, a fetus with a male partner that is rhesus positive, and the baby ends up having rhesus positive blood during birth, just the same way as infectious diseases like hepatitis can spread during the birth of a fetus, the rhesus factor, the mom can be sensitized to the fetus's rhesus factor. So her next pregnancy, she will have, if she was rhesus negative, she will have rhesus antibodies. And if she were to have a rhesus positive fetus in her second pregnancy, this could cause fetal-maternal complications, and it could lead to hemolysis in the fetus, which is not good. So if there are any questions about this, we can talk about this more later, but this is the fundamental compatibility structures that need to be considered when thinking about blood transfusion, and lots of the reactions and very important reactions happen when these are not considered carefully. So let me move on to transfusion safety. Okay, I'm going to put the chat down below. So according to what I just said, the ABO system being very important, it is very important to determine the determination of blood type is very important. And the first thing that has to happen for donors and for recipients. And I will get into bedside test, which is the confirmation of the patient's, the recipient's blood type right before the transfusion is administered on my next slides. As I mentioned, infectious diseases are spread by blood, and this is probably covered in other lectures more extensively, but transfusion is a very simple way to spread infectious diseases that are transmitted by blood, and is something to be very cautious about. Because it's basically, you would just be transfusing this infectious disease. And I have a list later on of the infectious diseases that are tested for and are on the questionnaires before you donate blood. Furthermore, there's a process called Leukoreduction. This is the reduction of the white blood cells in the donor blood, and I'll get into when this is important as well. And depending on if the recipient of the transfusion is a high-risk group, and I'll get into this later too, and my example here is, for example, if they are IgA deficient, they will need to receive blood products that have undergone further processing than the standard processing for healthy recipients. So let me move on and show you this bedside test. So the ABO system is specific to the red blood cells. Okay. When it's basically a blood transplant. And so when you're considering like kidney transplants or other organ transplants, you look at HLA systems, which are much more complicated than AB0. So this is a slide showing the process of the bedside test, and this is done right before a blood transfusion is administered. And there are various different forms of bedside tests. This is the one we use in Germany and is very popular. And I just like this diagram because it shows you what is happening. So this is a sterile, regular blood draw. And there are two, you can see this card has two pockets. And some cards have pockets. Some cards are just on cardboard and the antibodies are dried onto the cardboard in different areas. This varies on what your hospital or what the clinic has on hand. But the important thing is that all tests are the same and that they have a field with anti-A antibodies and anti-B antibodies. And a sample of the patient's blood, the recipient's blood, is dropped on or infused into this pocket of each antibody group. So if blood is put into the anti-A pocket and the anti-B pocket, and depending on which one agglutinates and coagulates, the blood group is determined. And that's why, because this is so important, that's why it's very important to understand the ABO system and which person has what antigen and what antibodies. So anti-A, anti-B, and this next slide shows the various combinations of what can happen. So somebody who has blood group 0, they have 0 antigens on their red blood cells. So anti-A antibodies and anti-B antibodies are not going to agglutinate or coagulate this patient's blood because there's no antigens to attach to. So if nothing happens, they have blood group with no antigens. Nothing happens, no antigens, so they are blood group 0. And the motto for these tests is what you see is what you get. And it's always the perspective of agglutination. So no agglutination means your blood group is empty, as in 0, no blood group, so to say. No agglutination, blood group 0. Agglutination in anti-A, group A. Agglutination for anti-B, group B. And agglutination in A and B, blood group AB. This is very important to know. So, and this is easily understood if you understand the ABO system. Okay. And the idea of these tests is, this is basically mimicking what would happen if you were to transfuse blood to the wrong patient. So if you were to transfuse blood that is group A to somebody who has blood group B, which means that they have anti-A antibodies, it would agglutinate. And that's not good. I have a few examples on the next slide, and if you guys are able, you can type it in the chat what the answer is. Okay, so remember, what you see is what you get. So with that in mind, what is happening on these slides? I'll give you guys a minute to text in the chat. What blood group does this person have of the middle bedside test? Perfect. 0. Yes. O. Because there is no agglutination. So what you see is what you get. We see no agglutination, so their blood group is 0 or O. Okay, so on the second one, what's happening here? The bottom bedside test. What blood group do they have? Text it in the chat. Okay, I'm seeing a lot of AB, and unfortunately it's just A. So the AB, it kind of, you can tell it's still very liquidy. There's no kernels. Oops, there's no tiny dark patches. So you can see how this does not look as liquidy and soupy as this here. So yeah, group A is the answer. It's agglutinating here. You can see these agglutination kernels. And this is not agglutinated. This is agglutinated. Yes. So group A. And this is what it looks like before blood is put in. It's just a sample of anti-A antibodies and anti-B antibodies. Okay, so 0 and A. And I didn't, so you can practice later, or for the people who are not here right now with us, the answers won't show up on the screen. Okay, so I mentioned the infectious disease screening, and exactly, so this happens when you're donating blood. So there's a questionnaire that is filled out by the patients about potential exposure and history of infectious diseases. And I also put medication on this slide just because it kind of falls into the same category. It's also asked on the questionnaires. Very often tested and important medication that prevents you from donating blood is the retinol, the isotretinoin for acne, which lots of young people are on. And as we know, this is a toxic medication to fetuses, and that is why you are not allowed to donate blood if you are on this medication. So depending on where you are and what infectious diseases are around, the labs often screen the blood products for different diseases. Common diseases that are screened for are HIV, hepatitis B and C, West Nile virus, Zika virus, syphilis, and Chagas disease. And in some regions, malaria and babesiosis are screened for too. And these would all prevent the blood from being used. Okay. Leukoreduction in some countries, for example, in the US, all blood products are leukoreduced. This reduces the risk of nonhemolytic febrile transfusion reactions. And if there are a bunch of white cells that are still around in these blood products, they produce cytokines, which then can produce or cause fever. They won't cause hemolysis. That's why it's called non-hemolytic febrile transfusion. But nevertheless, they will cause a transfusion reaction, which I will touch on. Diseases CMV or EBV can be transferred via the transfusion of white blood cells. So removing these reduces the risk of transfusing these diseases. And by doing this, the lifespan of the red blood cells that are transfused is increased. So most blood products nowadays are leukoreduced. I'm not sure if they are reduced everywhere, if all blood products are leukoreduced everywhere in the world. Not sure on this, but it's a good practice, and that's the goal will be to do that everywhere. So further processing, this is leukoreduction, and irradiation also targets white blood cells, and this is basically leukoreduction on steroids. This is irradiation. It's also targeting the white blood cells, and this is especially important when it comes to prevent graft versus host disease. So high-risk patients that are very susceptible will ideally receive irradiated blood products just to reduce this complication. And this is often found in patients with leukemia and other blood disorders. Washing is a procedure that is not done often, but for a certain group of patients, it is absolutely necessary. And this is for IgA deficient patients. So IgA deficient patients have antibodies against IgA. And when IgA is transfused in blood products, in the plasma that is in the blood products, they can develop anaphylaxis, which is a severe, one of the most severe blood transfusion reactions. So if a patient is known to be IgA deficient, and there are disorders where patients have selective IgA deficiency, then they will ideally receive washed blood products. This reduces the plasma and therefore reduces the IgA, so the patients cannot react to foreign IgA if it has been washed out. Okay, so basically all this processing, the leukoreduction, is just taking out more stuff, taking stuff out of the blood products that the patients could potentially react to. The healthier the patient, the less processing has to be done, and the more risk factors the patients have and the more preconditions, the more the blood products need to be processed. Okay, so pre-transfusion, this is talking about what actually happens right before transfusion. When considering transfusion for a patient, it is important to identify any special transfusion requirements. For example, if they were IgA deficient, or lots of arrows going on here. I don't know whose arrows these are, but yes. So it is important to identify any special transfusion requirements. Obviously, it is important to obtain consent when possible. In emergency situations, it is not always possible, but in the clinical settings, people with, for example, chronic kidney disease who have a very strong anemia that cannot be controlled with EPO, they are totally able to consent, and this should always be done when possible. Because of the risk of reactions, it is very important to transfuse blood products during regular working hours with the doctors on the ward. So these are not infusions that should be administered overnight when there's no one there. It is very important to confirm patient identity, which means the name, date of birth, and medical record number. So it is not enough to just ask the person for their name. It's very important to ask them for their name, date of birth, and to confirm their medical record number because of the serious reactions that can occur. It is important to confirm the transfusion indication. Is it absolutely necessary to transfuse this person? For example, if they are iron deficient, or if they are B12 or folate deficient, these measures should be tried beforehand before going back to so this is a measure of last resort when none of these other supportive measures are possible. When you have ordered blood products, it is important to ensure that the blood product is undamaged and that the contents appear normal. And it is important to prepare the transfusion with a special blood infusion set. And these have a mesh filter and are, in the hospitals I've worked in, also a different color. They're usually white, while normal infusions are orange. And special care has to be taken into preparing these infusions as to not to harm the red blood cells because they are sensitive. Okay. So let's get to the main. So the reason why there are so many precautions going into blood transfusion is because of the reactions that can happen, besides transfusing infectious diseases directly to patients, but the reactions are very avoidable, and that is why there's so much emphasis on them. So whenever you transfuse blood product to a patient, it is important to stay with the patient for the first minutes of the transfusion. So severe reactions, strong allergic reactions like anaphylaxis or mainly that can be very bad, and in these cases, the transfusion needs to be stopped immediately. So it is important to stay in the room with the patient for the first few minutes and make sure that the transfusion is not provoking any strong reactions immediately. It is important to monitor vitals and the clinical status for every unit transfused. So oftentimes patients will require 2 units of blood or 3, and just because the one went in fine without any reactions, every time a new bag or transfusion is started, it is important to monitor the patient for any adverse reactions. So let's get into the reactions that could happen. Okay, so there are the allergic reaction. This, if severe, can be the anaphylactic reaction. And because it's so severe, it's its own group. How can I get rid of the arrow and the line? I don't know how to do that. Eraser? No. Okay. Okay, the one who should. Yes, so there, okay. So let's get into the reactions. Okay. Allergic reaction, as I said, anaphylactic reaction. Then there's the febrile non-hemolytic reaction. We remember I already mentioned this when talking about leukoreduction. Then there is the hemolytic transfusion reaction, which is if you don't pay attention to the ABO system. And 2 other reactions that are good to understand and know about are the transfusion-associated circulatory overload, TACO, and the transfusion-related acute lung injury. They can both be severe, and it is good to recognize these and know what's going on because treatment varies and they should not be mistaken for anything else. Okay, allergic reaction. Allergic reactions are always, in this case, they're type 1 hypersensitivity. There's antibody formation against the donor plasma proteins, and the presentation can vary from minutes to hours. Prominent symptom is urticaria, pruritus, so itching, wheezing, and fever. And the treatment is to stop it immediately, administer antihistamines, epinephrine if severe. And once the transfusion has been stopped and it has been confirmed that this allergic reaction is only contained to urticaria or some itching, then you can resume transfusion. If it is not mild and the reaction gets out of control, it is anaphylaxis. This is a severe allergic reaction, and this oftentimes happens in IgA deficient individuals classically. This will happen the same time frame, minutes to 2 to 3 hours afterwards. And all the symptoms from allergic reaction are increased in severity. So the patients will be presenting with not only wheezing, but dyspnea, bronchospasm, hypotension, and anaphylactic shock. The treatment for an allergic reaction so severe that it is anaphylactic is to stop the transfusion, administer epinephrine like any anaphylaxis, and treat the anaphylactic shock as required. It might require respiratory support. This depends on their symptoms. As I said, this mainly happens in IgA deficient individuals who have IgA antibodies against the IgA that is administered to them in the blood transfusion. Okay, next slide, next reaction, febrile non-hemolytic reaction. So this is the one that we can prevent with leukoreduction. Febrile non-hemolytic. Non-hemolytic means that it is not, the red blood cells aren't being attacked and are not breaking. So this happens with the cytokine formation during storage of blood often by white blood cells. And there are also host antibodies against donor HLA antigenes. I mentioned HLA antigenes. They are very important when it comes to kidney transplants and solid organ transplants, not so much in blood transfusions, but they can, incompatibility can cause this febrile non-hemolytic reaction. This is type 2 hypersensitivity, and the presentation is fever, headache, chills, flushing, and it happens hours after transfusion. Since it happens hours after transfusion and the blood is not hemolyzing, it is treated with fever reduction, with acetaminophen, and preventative treatment is the leukoreduction of the donor blood. Yes, this is not that bad, and it is important to recognize this. It is important to recognize that the fever is from the blood product. This can, for example, happen after operations. If somebody is receiving blood products during an operation and they present with a fever 5 hours after the operation or later in the day, it is important to know that this could be the cause, especially if the patient is not showing any other signs of other fever origins. So it is, in a way, a diagnosis of exclusion. Let me move on to the big one, hemolytic transfusion reaction. So this is when the recipient has antibodies against the donor red blood cells. And this is the one that is very preventable by following strict pre-transfusion safety measures, including correct typing of the blood and of donor and recipient, and confirmation through a bedside test right before blood transfusion admission. So as I mentioned, and as the name says, this results in hemolysis, and it is often acute. So it will happen within the first hour of transfusion. And if it is based on ABO incompatibility, this happens immediately within the first hour of transfusion and intravascularly. In contrast, patients can also have a delayed hemolytic transfusion reaction, and this is the other antigen classification system, the Rhesus D, can happen within days post-transfusion, and this happens in the reticuloendothelial system, which is extravascular. So the patients will present with hypotension, fever, tachycardia, flank pain because of kidney damage, because hemolysis and the released hemoglobin is damaging to the kidneys, which will result in flank pain. Hemoglobinuria, which will happen in the acute hemolytic transfusion reaction because of intravascular hemolysis. And the delayed Rhesus D caused hemolytic transfusion reaction will result in jaundice because of the extravascular nature of this hemolysis. So, summarize, there's acute and delayed. Acute is the big one with the ABO incompatibility that can be prevented by the bedside test and correct typing of blood according to the ABO system. What is the treatment? To stop the transfusion immediately, because it is obviously the wrong transfusion. So if we're transfusing the wrong blood type, we need to stop the transfusion immediately and transfuse the right one the next time. In the immediate clinical setting, we should, because we obviously made a mistake and don't know the right blood type or don't have a different blood type product ordered and on hand, we might have to administer IV fluids, normal saline, to maintain blood pressure and good urine output, also to flush the kidneys to prevent kidney damage. It's usually acute tubular necrosis that happens from intravascular hemolysis, and this can cause acute kidney failure. And to prevent this, we flush the kidneys with IV fluids, normal saline. Okay, now some fun reactions, fun for understanding purposes. There's, and I think of these in a group. So we have the transfusion-related lung injury and transfusion-associated circulatory overload. So both of these have manifest with lung and breathing problems. And it is important to differentiate these two because the treatment is different. So the transfusion-related lung injury is a cell-based thing. It is, we have the two-hit mechanism, two-hit hypothesis, and some individuals, they will have neutrophils sequestered and primed in their pulmonary vasculature due to various reasons. So some people have neutrophils in their lungs just hanging out. And if these patients receive a blood product, these neutrophils can be activated, which will lead to an inflammatory response in the pulmonary vasculature. This increases the permeability and will cause a pulmonary edema, which is non-cardiogenic. So there are people that have an increased risk because they have neutrophils in their lungs, and after receiving transfusion, this can cause a kind of infectious reaction, which will lead to pulmonary edema that is very importantly non-cardiogenic. The patients will present with respiratory distress immediately within a few minutes of the transfusion to a few hours afterwards. The treatment is respiratory support, and usually it's not recognized during transfusion, but if it is, it would also be good to slow the transfusion rate and stop the transfusion. But usually it presents after transfusion and they're breathing heavily and people are like, what's going on? And it is important to distinguish this from the next reaction, but transfusion-related lung injury only requires respiratory support. Very important to realize because it does have a high fatality rate, so do not underestimate it. Moving on to the other one that presents with respiratory distress is transfusion-associated circulatory overload. So this occurs in patients that have an underlying cardiac or renal condition. Oftentimes, these patients are younger than 3 or older than 60, and they have been receiving large transfusion volume at a rate. And their body can't handle this large volume of blood that has been rapidly added to their vasculatory system. So this presents within hours of the transfusion. They will present with tachycardia, pulmonary edema, respiratory distress, a third heart sound, signaling volume overload, high blood pressure. And because these patients present with respiratory distress, and treatment is respiratory support. But because this respiratory distress is due to a pulmonary edema, which in a way is a cardiogenic pulmonary edema, it can be treated with diuresis. So both of these patients, the transfusion-associated circulatory overload and transfusion-related lung injury, will present with crackles and lung sounds. But it is important to know that if it is circulatory overload, you can diurese these patients and solve the problem. Okay, so those were the 2 lung breathing reactions, and those were my 6 reactions to blood transfusion, and I've added a few questions here for you to think about when reviewing this topic and studying later. But that's it from me now, and now I'm open to questions. I kind of put the chat on the bottom. Let's see what the chat says. Okay. So does anyone have any